All right, we're going to try this one more time. We'll see if this works. So, Tom, you'll have to turn your phone sideways. Once I see, there's a 2-minute delay, so once I see that you've logged on, I'm going to invite you into the conversation. Looks like somebody's here. That's you. I'm going to invite you sideways. If not, Tom will do the live, and then he'll invite me into the conversation so that way we can have this discussion. And then I'll try to follow the comments on the computer so that way I can make sure that we're not missing any questions that are being asked. Okay, it looks like it's inviting you. There we go. All right.
I should turn the lock off. My 9-year-old daughter figured it out for me.
You know, it's funny. So getting back to the conversation that I had with Rob Townsend, the teacher.
I'm gonna go in my. I've got four. I got 4 kids. So I'm gonna go in my car and talk.
Okay. So for everybody out there, I had this conversation with Rob Townsend a couple of weeks ago, and it took his 9-year-old daughter for us to actually have the conversation back and forth regarding how to use the iPhone to get onto Facebook Live. So, all right. Are you ready?
I'm ready.
All right, so go ahead and introduce yourself. Who are you and where are you from?
I'm Tom Lotus. I live in Chicago, not far from where Vince is. I'm a 2003 national grad from the National University of Health Sciences. And after chiro school, I went on and I did a 3-year residency rotation in orthopedics, completed a rehab diploma program, and then was asked to travel to Prague, Czech Republic, to do a residency rotation under the famous Karel Levitt and Pavel Kolaj. And upon returning from Prague, I started my endeavors into the McKenzie Institute. And currently,
what year was that, Tom? What year was that?
Oh, that was 2006, maybe, with McKenzie, 2007. And 2008, something like that. I don't even remember anymore. It's been so long, Vince. And you know, I've been in clinical practice for 14 years now, and getting prepared and ready to go abroad to do my diploma.
The diploma program for
MDT in the next 2 years.
Okay, so we actually have some guys that are in the diploma program on the interview, so they may be chiming in with some questions.
Oh boy, here we go.
So Clay's a PT out of New York. I believe he's near the Buffalo area, and he studied under Ron Shank, so he may be asking questions as we go along. So
Ron Shank's a mentor of mine. Clay, you're lucky there, man.
Yeah. So Clay asked if you're going to Scotland.
That right now, that's the only place to be able to go. There's been, at this point, I'll be going to Scotland. Let's just leave it at that.
All right, fair enough. And so right off the bat, I want to jump in with your bio. The rehab diploma program. What is that?
It's a 3-year program, weekend courses, in which we're taught once a month for 16 hours, and I mean we have people like Stu McGill and big researchers like that, Kowchuk, and those people come in, and we do a rehab program, and it's once a month for 3 years. It's the same thing with orthopedics.
Okay, so it's like a residency?
Diploma.
Okay, so like
there's no residency attached to it anymore at this point. No.
All right, and so it's optional is what it sounds like.
Yeah, it's postgraduate work.
Okay. All right. Now, Czech Republic. What did you do out in the Czech Republic?
Rotated with Karel Levitt and Pavel Kolaj through the hospital for about 3.5-week rotation.
Okay.
It was a selective invite. It was really cool to get to see some of the grandfathers of manual medicine work and pick their brain. It was an unbelievable experience.
Awesome. Now now we get to like the timeline where I actually get introduced to you. And so that's about 2007, 2008. After you started MDT, we met in the study group.
Yes.
And who was part of that study group?
I believe it was myself, you, I believe Melissa Kolsky, Maya was part of that.
Maya.
Curtis was part of that.
And Bill just signed on.
Yep, yeah. There we go, Billy boy. Bill Curtis, another mentor of mine. Thanks for all you've done for me, Bill. Shaped my clinical career.
Okay, so there were some other people involved with that, and regarding A World of Hurt. And
Melissa Kolsky, Annie O'Connor.
Yeah, Melissa Kolsky and Annie O'Connor. So now I want to jump right into one of the questions that was asked about classifying. You put something in there that, you know, we have to classify patients. What do you mean?
We have to subgroup patients. I mean, research shows that the more we subgroup, the more we classify, put the patient in the right subgroup and classification, the better the outcomes. And I firmly believe that until everybody, starting with the GP, understands some form of classification and puts the patients in the right hands, you know, we're going to continue to be in this epidemic that we're involved in right now.
Right. And so on a day-to-day basis, what type of patients are you seeing? I saw your post recently regarding the different patients that you saw that day and how you classified them. So on a day-to-day basis, how are you classifying patients, and what types of patients are you seeing?
Oh, we're seeing everything. I mean, if we want to go through the beautiful work that Smart et al. Did and that Kolsky and O'Connor beautifully put together in a book, and we look at the pain mechanism, I mean, I see anybody from what we would call in the McKenzie world, our mechanical derangement, or in the PMCS model, the nociceptive inflammatory mechanical patient, where, you know, as we know in the McKenzie world, that, you know, the right direction is almost like a miracle. It's a rapid response, you know, to the person that is all the way down the continuum in their autonomic motor, in which we look at some of Mosley's work and the work of NOI, and we're dealing with the primary somatosensory cortex. And instead of remodeling tissue like we do in mechanical dysfunction, we're modeling a central tissue. We're remodeling that primary somatosensory cortex, the virtual body, you know, so where their body's in space, the CRPS patient. Two, you know, many times we see the affective patients, the unconscious affective, the types of patients that the classified as TMS, tension myelitis syndrome patients, and of course the central sensitivities, which, if you want to use an analogy to central sensitivity, is, you know, Annie O'Connor always says, basically stinking thinking. You know, we got to change the thinking process. We got to decrease the excitability of the input, and, you know, once again, you know, it could be a rapid response. You know, we use the analogy that CS is just like our derangement in the brain, or in the peripheral nerve.
All right, so I first want to jump in and talk about my history with you a little bit, because I can remember sitting in the study group, and we'd be sitting back, and you're thinking so fast that I was having trouble keeping up. Okay, and so you just covered A World of Hurt in a synopsis in like 30 seconds. That's really hard for some people to follow. So I appreciate it, but I just want to make sure that we don't have anybody who's lost out there with everything that you just said. So if people have questions regarding everything that Tom just said, please chime in, because he covered a lot in a very short period of time. All right, so I want to move on, but I want to leave that open for questions to come in at some point. Now, there's a lot of, I guess, dissension is the best way for me to put it right now, regarding chiropractic and PT, and you know, and I talked to you about it a little bit today in some of the other groups that are out there. What's your opinion about this dissension? I mean, should it even be there?
No, it shouldn't be there. I mean, I've had this conversation on and off for the last 15 years. I've had this conversation with some of the authorities in Raw. I've had this conversation with some of our senior instructors and mechanics. You know, at the end of the day, I mean, our titles are different. We're just body mechanics. You know, we're just there as Mark Miller, like, is, you know, we assess until there's nothing left to be assessed, and we both do the same thing. Unfortunately, in our country, in some countries, politics gets in the way, and instead of creating a happier playing ground, what it does is creates tension between the fields, and with that, it creates tension within society. And with tension coming in society, I mean, the person that is getting harmed the most is the people that we're all supposed to be helping. You know, we're all supposed to be the patient's advocate. And until we understand that we're all doing the same thing and we're trying to do the same thing, it's going to be a lot, unfortunately. You know, I mean, there's so much contention. I mean, there's contention in the PT world itself. There's contention in the chiro world itself. There's contention. There's contention in the orthopedic world. You know, it's a shame. You know, it really, really is a shame.
All right, so there's a couple questions that are coming in on this topic. I figured they would. The first one, I'm going to go to Hirsch first.
Yeah.
Why do you think that this problem exists? You just kind of gave politics, but why is there so much tension between the two fields?
I don't know. I'll be honest with you. I really don't know. You know, I really believe that stems from the people that we learn. Sorry about that. I got a little close there. You guys been my dentist there for a second. It stems from the people we learn, that we learn from, unfortunately. Sometimes it stems from political battles of fighting for money at the end of the day. I mean, let's face it, at the end of the day, a lot of it comes down to money. And many people argue, and, you know, my wife too, and she lectures around the country and around the world, and she always says, what's really, really funny is the people that argue are the non-players. And the people on top of the hierarchy, they all get along, whether it's a chiropractor, whether it's a PT, whether it's an orthopedic, internal medicine doctor, they all know each other, and somewhere at some point they're sitting having a scotch or a glass of wine talking how to help the patients.
That's true. I do remember our times that was the Blue Iguana down there, right around, all having a drink, discussing patients. And so Hirsch followed that up with, how can we change the system?
Yeah, you know, Hirsch, I'm going to speak directly to you since you asked that question. If I knew that answer, I think you would know that answer, and I don't think we'd be having the problem we're having right now. I don't know how we change that. I think the beginning and using it as a catalyst is kind of like what we're doing right now. You know, I mean, we all have to talk at the ground level and hopefully gain enough respect for each other. And once that happens, hopefully society does, and, you know, hopefully the outcomes all show the same result, and things down the line just change.
Adam Sivitz, he's a student over at UIC. He asked the question, when a patient asks you what's the difference between PT and chiropractic, what do you tell the patient?
I tell them there is no difference.
Awesome.
There's no difference. Here, put it this way, Vince, is the PTs that are doing a good job and the chiros are doing the good job, we're all doing the same thing. You know, unfortunately, like, you know, the one major difference is chiros have direct access. Unfortunately, PTs don't. I think they should. I've PTs, I know PTs that are far superior than 90%, 80% of the chiropractors I know. And I've met chiropractors I know that are far superior than the PTs. And I met chiropractors and PTs that are far superior than any PM and ortho. You know, so a major difference is that direct access and gatekeeping role, unfortunately. But if we all class or utilize, let's just say McKenzie, since there's so many McKenzie people on, if we all classify, you know, the same way, at the end of the day, there is no difference. What a chiro would do, unfortunately, and we're changing this, okay, what a chiro would do is a chiro that's not trained in McKenzie is they'll just bring him to exchange loading right away without progression of forces. As where a a well-trained chiropractor that understands McKenzie loading strategy and understands symptom response, they are going to know, number one, for patient safety and for the doctor safety, we're going to use progression of forces.
Can you explain? There's some PTs on here that aren't MDT trained. So can you explain progression of forces?
Yeah, I mean, it's basically finding a direction that we can move the joint or tissue that abolishes the symptom or centralizes the symptoms. And if we could find that, I believe the most current research shows that if we could find that, we know with a very high reliability, over 90%, that the patient's going to do really well, their direction to move. And when we do that, what a chiro does is most chiros won't look for a direction preference. They're not taught that in school. So they're going to use their palpation skills and they're going to adjust that joint. The problem with it is the reliability alone on palpation is very, very low. And instead of just going that route, what progression of forces means is take.
You're breaking up. I don't know if you can see it, but you're breaking up, Tom. So looks like we lost him here for a second. Real quick, for some of you that don't know, Bill Curtis is also. Yeah, Bill introduced me to MDT, and so Bill is a PT out of Tinley Park. He has. I'm looking for you, Tom, to see if you pop in here. He has a clinic called PT and Spine in Tinley Park. He's the one who introduced me to MDT, and we did the study group together way back when in 2007. He was doing it well before that. Let's see if I can invite Thomas back. Sorry if you can't see anything on here. I'm not quite sure what you guys see, but trying to invite him back into the conversation. Okay, so Tom, where are you? Looks like I invited him again. If you guys, there we go. Invite.
Oh.
Yeah, sorry, we lost you there.
I don't know what happened there. Sorry about that.
Yeah, so we lost you where you were describing directional preference, and it's not taught in chiropractic school.
Right, it's not, and I'd like to come back to that too once I finish the statement, because I've got something very exciting to announce about that too. Is, basically our progression of force is having the patient generate the force themselves with a direction movement and progressing it into patient-generated forces to patient-generated forces with overpressure to patient-generated forces with doctor over or clinician overpressure to mobilization and then to manipulation. That itself is a built-in safety net for the patient, for the clinician, and it creates self-efficacy, which is another big problem that we have in both of our communities, is not promoting self-efficacy enough, even though everybody's jumping on the bandwagon these days, it seems like, which is good.
Yeah, it's about time. So what was the statement you were going to make?
So, speaking to anybody that's in McKenzie, I've heard of McKenzie, is what's really awesome is that McKenzie MDT is now an elective in a chiropractic school, which I don't think there's a PT school across the nation that has that. It is built into their curriculum. And the big Fountainhead out in Iowa, I just came back from there. Man, I had such an experience. I mean, the minds out there are unbelievable what they're doing with research. They've integrated McKenzie A, B, and I'm not sure about C or D. It is part of their elective track at that school. So that by the time they graduate, if they decide to go the mechanical route, they could have McKenzie A and B completely completed by the time they graduate, which is exciting.
That's awesome. And so there's one PT school in the country that I know is doing it, and that's Clay's school over there where Ron Shank is at Damon College.
Right,
So,
right.
so of course they're bringing in A and B.
Right.
All right. So with that, you mentioned your wife. Your wife also teaches. I got a chance to peek in on some of your guys' coursework because you go live with some of that. What do you guys teach? Are you teaching together, or is she teaching? What's being taught?
We're not teaching together, and sometimes we are teaching together. Let's just put it that way. I'm fortunate enough, to help Mackenzie out, the USA branch out with assisting a lot of the classes. I've been asked in the past. I was a keynote speaker at the Denver symposium that we had, and I've helped develop I was a part of the Chiro branch, which is really good for the chiropractic field, to know that they have something within the Mackenzie Institute International. But at the same time, be very careful with that. My biggest fear is that what I've tried to do for the last 10, 12 years being associated with Mackenzie is blending in. So people I talk to don't know chiro, and not because I'm embarrassed, but all do the same stuff. And then like look at me just like, hey, we're all therapists. I'm not the chiro, you're not the PT. We're all in this for the same reason. So my fear and something I hope does not happen, and anybody that's involved in branch, I hope you don't allow, because I think it's really important just to say that our two professions come together, and they come together for the bigger purpose of advocates of the patient. So I've been able to help with that. I've been lucky enough to Andy Connor, Melissa Polsky, dear friends of mine. I was lucky enough to be affiliated with their hospital and introduced into the world of hurt from its very beginning. I've been honored to be asked to help teach the material, introduction to it, and help around the chiro world. In fact, I just taught to Palmer, the big chiropractic school out in Davenport. Their homecoming had about 5,000 people there, which was just insane. I was lucky enough to have 150 to 200 people. Now we're bringing a world to Palmer out in Davenport. So in 1 year, Palmer students and postgrad will be having Mackenzie instilled into the elective and a world of hurt instilled into the graduate elective, which is just
amazing.
Asinine, if you ask me. I mean, it's just unbelievable what that school has done.
That's amazing. I did see your post while you were at Palmer, the picture you put up. And so yeah, I think that a lot of us can learn from you and use you as a resource for not just, chiro PT, but treatment. And that's one of the reasons why, we started this group up, is to try to push the profession of healthcare forward. This is, like I said before, this is Charlie's group, but I feel the need to come in here and make sure that we're all on the same page and that we're trying to get the patients better. Now, you sent me a comment a little bit earlier today where you said the top 5% are doing, roughly the same thing when you look at chiros and PTs. What do we need to do to bring up the other 95?
Oh, Vince, that's a loaded question, man. I mean, should we start at Capitol Hill, or should we start with each other in our own personal clinics? I mean, because that's a continuum. I don't know. I mean, let's talk politics really quick, and then let's get out of it as fast as we can. Do I believe everybody should have health care? Yeah, I do. Do I believe socialized medicine? Not when I own my own clinic, I don't. Do I believe that healthcare reimbursement should be based on outcome productivity? You're damn right I do, because when I'm getting people and discharging, like many of us are doing in 5 to 6 visits, and you've got some other corporations that are seeing people PT or DC, right? Or and they're driving around in a Maserati, and I'm sitting in a cracked window with 4 kids. I mean, that's a problem. So I think there's so many problems. I mean, I don't know the answer to that. You know, what do we do to get that other 95% up top five? Is the answer is going to come down to hopefully teaching everybody how to classify for better outcomes. The better outcome you get, the better reimbursement you get. Because at the end of the day, whether we're dealing with a university, whether we're dealing with a private or a hospital, at the end of the day, the group of people sitting at a round table saying, what Tom Cruise is known for saying is, show me the money, or whoever it was in that movie. You know, they want to see money. That's what everything is driven on these days. Even the insurance company. I mean, if we think the insurance companies want to see patients only 5 or 6 times, we're smoking something, because that's the case. They want us to see them more, and then the middleman cut us so they win on both ends. If we see them more, they could jack the premiums up, right? So premiums go up, and then we say, well, wait a minute, you're denying us after 6 visits, and you said another 3 visits. Well, the middlemen are cutting up the treatment for us. So they're winning on both ends. And, you know, companies are just an investment company. What they are, they take the money, buy real estate, and they invest their money for 30 to 90 days, and take the money out, give us our check, and then they wait for the next month. And they're just investing. Is that a problem? Yeah, it's a problem, but it's what makes America America too. It's a capitalist country. You know, so, I mean, I don't know that answer. And once again, if I knew that answer, Vince, I wouldn't be sitting here talking to you today. I mean, I'd be sitting on my island somewhere.
So I want to touch on a couple of things that you just said. The first one, Clay, I know you're out there, so maybe you can help me out with this. If you could link the interview from the mechanical care forum, I don't remember which one it is, but Jason did an interview with an insurance rep. And so if you could link that interview onto here, because that covers a lot of what Tom just talked about. The second one is Adam. You had asked the question previously, and you've heard it now from 3 different people, that 5 to 6 visits, right? I mean, I didn't prep Tom to say that. That's how many visits he's doing, and that's what we tend to see in private practice when we're utilizing some sort of classification system. Tom, can you walk me through the history of your visits? So, like, right now you're saying maybe 5 to 6 visits. What were you 10, 12 years ago?
10, 12 years ago before McKenzie, I was still hitting good markers. I was probably somewhere around, you know, anywhere between, you know, 14, 15, 16, which, you know, I'm still proud of that. You know, I mean, if we look at the average of what most people are doing, unfortunately, if you fall under 15 to 20 visits, you're doing a damn good job. Now, I mean, those visits are going to differ between everybody. I mean, it's, you know, our we know our rapid responders. Our dysfunction, we know, take longer. But the beautiful thing about a dysfunction is once we rule out a derangement, I mean, we don't need to see that patient once a week. We can push that patient out once every 3 weeks, because we know from a histopathophysio standpoint that it's not going to respond in 1 week. Do you understand? I mean, like, you know, so even though a dysfunction is going to take longer for the patient to heal, that does not equate to us seeing the patient more. And that's something that everybody needs to understand.
Yeah, and so and that's one of the things that at least those of us on here that practice MBT, we try to push that out there, that, yeah, it may be less productivity in terms of dollars into the clinic, but it's right for the patient in terms of that fiscal responsibility. And we're going to get the patient better as long as we can predict what's happening there with that dysfunction. It's just going to take a little bit more time, but that doesn't necessarily mean more visits. So Hirsch, I'm going to come back to you now with this question. Hirsch asked, how often do you get to do physician education regarding pain and classification? And do you meet any resistance from the physician? And if so, how do you overcome it?
Every day, and hardly any resistance. How's that, Hirsch? I mean, there's not a day that goes by where I'm not text messaging PM&R doc or talking to an orthopedic surgeon on the phone. There's not a week that goes by where I'm not spending a day at Northwestern or at Rush. I'm integrated with these orthopedic surgeons, these hip surgeons. And, you know, the beautiful thing, when you could show a reduction in a patient that has got peripheral symptoms in front of a surgeon's eyes, it's like their jaws drop. And that's all the education you need. And then you just support it with the research. Some of the, I mean, it's, you know, more of the resistance comes from, it's hard, I hate saying this, but some of the older clinicians that just don't understand what we're doing, or they're so set in their own ways. And it's like that in every profession, I'm sure. But, you know, educating the physicians has done wonders for my personal clinic. I mean, I get referrals. I had 22 referrals 2 weeks ago from orthopedic, was because looking for MDT and they're looking in classification. They don't want those. No matter, they don't know what to do with. They want good outcomes too. So they want the patient where everything has failed. They're not centrally mediated pain, and they can go in there and they can remove something, and the likelihood of the patient being better is high. That's right. What they want. So our job is to educate them and say, listen, this is what we know from research. We know if we could classify these patients properly, half the time you don't have to see 50 patients in a day and end up having 5 surgeries out of that. Wouldn't you rather have 15 to 20 patients a day, right? And out of those 15 to 20 patients, you have 90% that are surgical. And their jaws, like, yeah, that's what we want. Now that surgery an extra day in surgery where they've been trained to be, and less time fishing out through all these other patients that really don't belong in their schedule. That problem stems from, in the hospital setting, in my opinion, the GPs or internists that work in the hospital, when someone says, I've got back pain, I've got shoulder pain, I've got knee pain, they don't understand the classification that we know so well. So what they say is like, go to the surgeon. Now, the surgeon's backed up for 3 months, and half their patients.
You mentioned one thing in there that I want to jump in on. Are you doing live demos with your surgeons?
Sometimes. Okay. I've got relationships with a couple of the hospitals and with a couple of the surgeons where I'm there, and they look at me and they'll say, they won't say Tom Lotus, the chiropractor, what do you think? They'll say, Dr. Lotus, what do you think about this patient from a mechanical standpoint? Where would you go with the patient? And they're very humble, and we have that type of relationship. And that relationship from, you know, all my residents that rotate with me, they say that comes from just being yourself and coming off the pedestal of thinking like we're better than, or PT wise, wise, surgical wise, PM&R wise, and just being able to have a conversation and being a human being, and letting them know that we're all here for the same reason, each other. And with that mutual respect comes trust. And once trust is there, then it says, hey, can you show me what you would do with this patient? Yeah. I mean, flexion rotation with this patient, you know, right flexion rotation. Why would you do that? Because they're already sitting offside like that. That's my predictor. They've tried McKenzie. They've tried the extension McKenzie. They've gotten worse. Flexion rotation. Oh, really? Yeah. All right. Well, flexion rotation. Would you mind? Boom. Simple or better. You know, it's that trust. And when you see a response like that, I mean, it just opens. It's a flood.
Now, you mentioned in there that you've got that relationship with the surgeons. With me, I've educated some of the primary care physicians on the start back tool, you know, for when to send to PT, when they might need something. I think we might have lost. Oh, there we go. When they might need something totally different. Are you doing any marketing or any education for primary care? Can you hear me? I don't know if I lost them or not. You might have yourself. Nothing. I'm gonna makes for a good conversation if nothing else. I almost feel like I want to do the line from what is that, Jackie Chan? Can you understand the words coming out of my mouth? We'll try this again.
My back?
There you go. I got you.
All right. Good. I can't leave now. I'm having too much fun with this.
I just want to make sure nobody else has asked any questions. All right, so yeah, getting back to it, have you done any marketing or education for primary care physicians?
No, I really haven't. To be honest with you, I mean, I've tried that in the past. I have some of my associates trying it. You know, and I really spend most of my time where, um, I spend most of my time with the PM&R team and with the orthopedics, honestly.
Yeah, you know it's funny because I think I've had the most success with PM&R docs. Now that I
Yeah,
think about it, more so than the surgeons and the primary care physicians. I don't know if
yeah.
it's just being in a hospital setting or being around a hospital setting for so long. It's hard to say. All right, let me see if I got anything else that comes out of here. Physician, no. All right, anybody else out there have any questions? Otherwise, I'm going to let Tom plug away anything that you want. Anything that you want to talk about in terms of your business. What's your business name? Where are you located? What classes are you teaching? Any products that you guys want that you're looking to sell?
No, I mean, I'm not looking to sell anything, Vince. I'm just looking to sell, hopefully, that people, you know, we all join in the same team, you know, for our patients, really. You know, I mean, I'd like to talk, you know, I just hope this helps and that one, Cairo, you know, we appreciate, you know, there's no animosity on the Cairo side, and we appreciate everything that you've done. And, you know, Robin McKenzie is a P. I mean, the people I've learned from are P's, like, you know, and, you know, I know many P's that have learned from Cairo's, and I really think that, I hope that if we all come together that, you know, we could have mutual respect for each other and have that common goal of, you know, betterment of the patient. Because, I mean, I love Mac. Every time I'm done lecturing, I throw the picture of Mac up, and with him sitting up on that fence saying, remember, we're all here for the patient. You know, that's why we're here. And hopefully that's why we're having this conversation is, you know, and every time, you know, to lecture here and there for the world of hurt, you know, I break down with tears sometimes in the middle of the lecture when I start talking effective pain. And I'd like to, you know, the Palmer School, what they're doing with our VA hospitals and the vets is just unbelievable. I mean, we've got that university has got. I'm not sure. I know Nate's on here, so Nate, I don't know if you could chime in by text of how many DCs we have in the VA hospital through Palmer, but we do know that almost every DC that is in the VA hospital has some form of McKenzie training, and they're implementing a world of hurt into that education for the VA hospital for the pain management. And I mean, we talk affective pain and PTSD, and I was at homecoming this last year, honored the lecture next to some of these chiros that are doing so much for the people that stand that line for us, so we can have this conversation. You know, the veterans that need that help, and listening to veterans talk, you know, on the key stage of how McKenzie has affected them and how much understanding of affective pain that comes from MCS has helped them. They're able to get off opioids. Man, we're in this together. You know, we really are. We're epidemic, this pain epidemic, and you know, we've got the government just pulling drugs away because drugs have gone so crazy over the years. It took the other. We really have to come together and do the thing that, or whether it's PT or D or MD in here, you know, and we just have to work as a really strong team and stop the separation.
Right. So now there's a few things that came up just now. So Nate answered your question. He said there's 125 total, not just over at Palmer. Two questions came in. One said, are you insurance-based or cash-based? How do you get paid?
I'm insurance-based.
Insurance-based. Okay, Hirsch, I don't know if you had a follow-up to that, but that answered the question. Adam asked, are you still using DNS in practice?
I use DNS on selective patients. So if we want to talk a little bit about a world of hurt, I will use DNS in a world of hurt or the PMCS models classifications of autonomic motor, because we know from Prague that DNS is primary somatic cortex stimulation. So I'll use that as a catalyst, and then I'll integrate Mosley's NOI work with body imagery and left-right discrimination stuff. I will also use DNS or infant reflex locomotion with affective, unconscious affective patients, because we do know that it does stimulate the social emotional centers of the brain, and it does activate the diaphragm, and we do know the diaphragm is usually restricted with patients with depression and anxiety. And I will also use it with nociceptive ischemia patient with the subclassification of kinetic chain once I work them from a mechanical standpoint. So if I'm dealing with an elite athlete from Colorado Springs or something, I may fine tune some things. It's not my big gun on my hip. My big gun on my hip is my assessment. And as Mark says, I assess mechanically if it's there, and if it's not mechanically, I'm assessing the brain, and I'm going to assess until there's nothing left. And what's important to remember is that somebody could be fully mechanical one day and come back the next day and have potential sensitivity. So we have to know how to balance with it.
I want to jump in on a different thing here. So they range from people watching this video from people who have 20 years of experience to people who are still in PT school. You mentioned 4 kids, you're running your own practice, you're citing a ton of research. Where's the work-life balance? That's the same look I give too when I get asked that question.
So I have TMS myself, man. I'm a perfectionist. I'm pushing and pushing and pushing, and unfortunately, one of my biggest things, and I'll get to your answer, but it's kind of a long answer to your question, is when I got asked to lecture in Denver at that McKenzie symposium, there was one mentor I've always wanted to meet, and it was Robin McKenzie. And I'm going to get a little emotional here because he means so much to me. But he's the one guy that, I don't know, he passed 3 months before. And at that point, I said to myself, I need to do something, and I don't know what it is. I'm going to introduce McKenzie as much as I can to the DC world and hopefully change the image of DCs and hopefully change the DCs to help better our society. And I made that promise. That summer before I lectured, and I'm not going to stop until I could look at my profession and say, we're on the right path. And with that comes countless hours in the clinic like we all do. Like that comes countless acceptances to invitations with research. And to write, this year I wrote 2 chapters. I was privileged to write a chapter with Richard Rosedale on McKenzie for Craig Levenson's 3rd edition of his book, Rehabilitation of the Spine. And I was privileged and honored to write a chapter with Annie O'Connor that's being published in NASA's Orthopedic Knowledge Update on all PT and all rehabilitation is not the same, which is basically what we're talking about here. And I think once I could look at some of my students that I've had and I've impacted, and I see them doing that, at that point, maybe I could step back a little bit. And I need to get a gatekeeper role. So my last stop is I'm going to push until I'm solidified as a full-time gatekeeper within an orthopedic group. And then I know that the right people are going in the right places to the best of my ability. Now, when it comes to family, I got the greatest wife in the world because she's a workaholic and an educator like I am, so she understands. And my kids, I try to get home 2 days a week early. And when I'm not lecturing, the weekend is theirs. It revolves around them. And whatever they want to do, I'm going to do it because one day I'm going to look back and say, damn, that time went by too fast.
Right.
And at the end of the day, too, is like, why are we all doing this? It's like if we take 35,000 steps back and look at the big picture, our kids are all going to be patients someday. So hopefully we can make a change for them, too.
So that's a great way to end this conversation, man. Because
because I know Nate's on. So Nate was a student. When he was in fourth try, he's probably laughing his ass off right now because we laughed all weekend about this. When he was in fourth try, he asked me if he could shadow me. And I don't remember that. He told me that I said, you don't know enough yet to shadow me. And that, for someone like Nate, all it did was drive Nate to become a perfectionist and to learn more. And it is awesome. I mean, I lectured next to him this weekend, and I mean, what this young doctor has done in the research world and what he's done with the VA hospital is just unbelievable. So, you know, hopefully this torch next year or two is going to be thrown to Nate, since he doesn't have as many kids as I do, and he takes it to the next level.
So yeah, so he's watching, and he said, no sleep. That's the key, right?
We're going to sleep too much later on in life, man.
Awesome. Anything else that you want to add, Tom?
That's it. As long as there's no other questions, I'm done. But I want to clear the slates right now. We're all the same.
Perfect. Thanks for your time.
Appreciate it, guys. Thanks for listening, everyone.
Have a good day. All right, so there you have it. There's Dr. Tom Lotus. He's out of Chicago. You can find him on Facebook. You can find him, obviously, you can Google him and find him on the internet. If you guys have any questions, feel free to chime in. I'll get these back out to Tom. I don't know how active he is on this group, so if you have any questions, I'll pass them along, and either he can come back on later to answer the questions, or Bill, thanks, man. I'm glad to see you stuck around this time. Tom's a great interview, you know, and we kind of both owe it to you for where we're at right now with our careers. So thanks for that, man. Yeah, again, if you have any questions, pass them on to me. I'll make sure that Tom gets it. Thanks. Have a good day.